Hello everyone, this is Dr. Sangeeta Chaudhary and again I welcome you all to my lecture class. Today I am going to discuss about systemic sclerosis, which is also known as scleroderma. This is just to show you the picture of a patient having scleroderma presenting with microstomia, pursed lip and radial furrowing surrounding the lips. This is a connective tissue disease which mainly affects the skin, vasculature and internal organs. The hallmark of this disease is Raynaud's phenomena plus sclerodactyly. Sclerodactyly means thickening of the skin of the fingers. Later we are going to discuss about Raynaud's phenomena. If we talk about the incidence is much more common in female. The female-male ratio is 4:1. The peak age when the disease appears is in between 4th and 5th decade of life. Scleroderma or systemic sclerosis can be of two types. It can be diffuse cutaneous systemic sclerosis or limited cutaneous systemic sclerosis. Limited cutaneous systemic sclerosis is also known as CREST syndrome. CREST stands for the mnemonic, where C denotes calcinosis, R denotes Raynaud's phenomena, E denotes esophageal dysmotility, S denotes sclerodactyly, and T denotes telangiectasia. We are going to discuss about the difference between diffuse and limited cutaneous systemic sclerosis later on. Now, let's talk about what is Raynaud's phenomena. We have seen in SLE class also the patient may present with Raynaud's phenomena. Now in scleroderma also we are seeing patient may present with Raynaud's phenomena. Now what is Raynaud's phenomena? Raynaud's phenomena is an autoimmune condition. It can be primary or secondary. Primary means there is no underlying cause for Raynaud's phenomena, whereas secondary means there is some underlying autoimmune condition. Just for example, patient having Raynaud's phenomena along with scleroderma or SLE. Now what happens in Raynaud's phenomena? You can just remember with the mnemonic PCR. This is not given in the books, but just for remembrance, easy remembrance, you can remember it. Okay, P stands for pale, C stands for cyanosed or blue, R stands for red. Now, what happens is that in a patient who is having Raynaud's phenomena, as soon as the patient hands are exposed to cold, okay, maybe cold water, then the patient's fingers becomes pale, okay, and this paleness is due to vasoconstriction in the particular area. For example, in this picture you can see this part of the patient's fingers has become really pale. So this is because of vasoconstriction. Next thing what happens is that this area will become cyanosed or will look bluish because of increased level of reduced hemoglobin in the particular area. And when the blood supply gets re-established again, this area will become hyperemic or red. So P stands for pale, C stands for cyanosed, and R stands for red. So this is actually the chronology of the color change in a patient of Raynaud's phenomena. If the Raynaud's phenomena persists for a long time, then ultimately the patient will develop digital ulceration also. Now let's see what are the difference between diffuse and limited systemic sclerosis. 33% of cases we see diffuse systemic sclerosis, whereas limited systemic sclerosis we see around 66% of case. In diffuse systemic sclerosis, the Raynaud's phenomena appears quite later. Okay, before the Raynaud's phenomena there will be skin thickening, and skin thickening, it extends proximal to the wrist or it may be truncal also. And there is associated significant visceral involvement. Whereas in limited cutaneous systemic sclerosis, the Raynaud's phenomena will come long before the other manifestations, okay, like skin changes, joint involvement and all. Before that, long before that, the Raynaud's phenomena will appear. Whereas we know that in diffuse cutaneous systemic sclerosis, Raynaud's will appear later. In limited cutaneous systemic sclerosis, the skin changes are limited to face, neck and hands. It does not extend beyond the wrist or not in the trunk also. Okay. In diffuse systemic sclerosis, we have known that there is significant visceral involvement. But in case of limited systemic sclerosis, visceral involvement like cardiac or renal involvement are less frequent. But one thing you remember that isolated pulmonary hypertension is more common in limited cutaneous systemic sclerosis. And the disease course is fairly constant. Now, if we talk about the etiology, the exact etiology is unknown like any other connective tissue disease. But certain environmental factors play a role, okay, play a possible role, like exposure to silica or exposure to vinyl chloride. Now, about the pathogenesis, this is an inflammatory condition, autoimmune inflammatory condition. So, there will be skin infiltration by T lymphocytes and fibroblast. Okay. So, because of activation of fibroblasts, there will be increased production of type 1 collagen, and this will ultimately lead to skin thickening. There will be arteriolar narrowing because of intimal proliferation. Okay, and because of arteriolar narrowing, there will be compromised blood supply to different organs, ultimately leading to organ failure or different manifestations. There will be endothelial injury also leading to ischemia. So these are the pathogenesis of scleroderma. Now, if we talk about the clinical features, the cutaneous features be like Raynaud's phenomena. We have already discussed what is it. The non-peeling edema of hands and tight shiny skin. So when you are asked about the causes of non-peeling edema, you can mention scleroderma also. Sclerodactyly, that is thickening of skin of the fingers. There will be dilatation of capillary loops in nail bed or telangiectasia. The facial involvement, initially I have shown you a picture of a patient of scleroderma. There will be tight pursed lips, puckering, microstomia. There will also be radial furrowing. Okay, as you can see in this picture, there are small radial furrowing surrounding the lips. There is microstomia, means patient is unable to fully open his or her mouth. Okay, and there will be pinched up nose also, which is not visible in this picture. Okay, this is the hands of a person having systemic sclerosis. We can see the shininess of the skin. The skin is shiny, and there is also thickening of skin. You can see it in these areas. Okay, there is skin thickening, and because of skin thickening and contracture, the patient has developed certain deformities also. In this area, you can see the swelling of the tendon sheath, the swelling of the extensor tendon for the middle finger. Okay. Here you can see the thickening of the skin of forearm. This is normal, and this is the skin thickening where the skin cannot be pinched in between thumb and index finger. This is a picture showing digital ulceration, which may occur in patients having Raynaud's phenomena, long-standing Raynaud's phenomena. This picture shows proximal scleroderma. We have already mentioned the features previously. There will be pinched up nose. Okay, then there will be radial furrowing surrounding the lips, microstomia. Okay. Some other pictures showing certain manifestations of scleroderma. Calcium deposits, also known as calcinosis. The fingers are puffy here. Okay, this is Raynaud's phenomena. Already we have seen one more picture also. Look at the paleness in the fingers and digital ulceration because of long-standing Raynaud's phenomena, digital ulceration and scar. In the musculoskeletal system, the patient may have arthralgia, morning stiffness, erosive arthropathy is uncommon, like SLE. In SLE also, erosive arthropathy is very uncommon. Muscle weakness. In the GIT, the patient may have esophagitis. Okay, the patient may complain of dysphagia or odynophagia because of esophagitis. There may be recurrent upper GI bleeding because of GAVE. GAVE stands for gastric antral vascular ectasia. Okay, it's a vascular anomaly which is also known as watermelon stomach. So because of GAVE, the patient may have recurrent upper GI bleeding. The patient may have malabsorption or SIBO. This stands for small intestinal bacterial overgrowth. In the cardiorespiratory system, the patient may have fibrosing alveolitis in the lung, pulmonary hypertension. Okay. We have seen that isolated pulmonary hypertension is more common in limited systemic sclerosis than diffuse. In the heart, the patient may have myocardial fibrosis, cardiomyopathy, or conduction blocks. In kidney or renal system, the patient may have malignant hypertension with hypertensive crisis. This is a medical emergency. Or patient may have acute renal failure. Now, how do we diagnose a case of systemic sclerosis? The diagnosis is the major part of the diagnosis is made through examination of the patient's symptoms and the signs. On clinical examination, whatever signs we're getting, these are enough to make a diagnosis of systemic sclerosis, though we will need help of certain serological markers. Okay, so we can, in the serum, we can test for anti-nuclear antibody. We can test for anti-centromere antibody. This is specific for limited systemic sclerosis. Anti-topoisomerase antibody or anti-SCL70. This is specific for diffuse systemic sclerosis, or anti-RNA polymerase 2 antibody. These are the autoantibodies which we can look for in a patient in whom we are suspecting systemic sclerosis. Then in the treatment, before we begin the treatment, we should make the proper diagnosis and classification. Okay, and we should have some differential diagnosis in our mind. Like for skin thickening, differential diagnosis can be amyloidosis, can be sarcoidosis, myxedema, or overlap syndrome, or mixed connective tissue disease. For vasospasm, acral vasospasm, it may be due to primary Raynaud's or autoimmune rheumatic disease, vasculitis, or some hematological abnormalities. Okay, so these are the few differential diagnoses which we should keep in mind. And coming to the treatment, we should ask the patient to try to avoid cold exposure, because most of the time cold exposure will lead to Raynaud's phenomena in these patients. Skin care is advised. Then as a treatment for Raynaud's phenomena, we can use nifedipine, that's a calcium channel blocker. Losartan can also be used, it's an angiotensin receptor blocker. Ipoprostenol can also be used. And then for lung fibrosis, steroids and cytotoxic agents can be used. For pulmonary hypertension, sildenafil, phosphodiesterase 5 inhibitor, sildenafil, or bosentan, this is endothelin receptor antagonist, this can be used. And ACE inhibitors, okay, angiotensin convertase enzyme inhibitor, is used for renal crisis, which I have already mentioned that hypertensive crisis or renal crisis is a medical emergency. So in that case, ACE inhibitor should be used. If we talk about the prognosis, basically there is no cure for the disease, but the disease can be controlled. It's a treatable disease and the manifestations can be controlled. And 5-year survival is close to 80%. So it is not so bad if treated on time and treated with proper medications. Okay, thank you for following the class.